अस्सलाम वालेकुम, मैं मेजर रईस मेडिकल स्पेशलिस्ट CMH कोयटा। आज हम आपको सिस्टेमिक लूपस एरिथेमेटोसिस के बारे में थोड़ा सा ब्रीफ कर देते हैं, थोड़ा सा हम आपको बता देते हैं सो दैट फिर डिटेल से आप लोग खुद भी पढ़ सकते हैं। हम बेसिकली केस प्रेजेंटेशन से स्टार्ट करेंगे कि वाइफ a female 30 years old XYZ, she was a resident of Bhimber, she was housewife, came with 6 month history of fever with on and off pattern, low grade and easy fatigability and joint pains. She also complains of weight loss, vomiting and shortness of breath for last 2 weeks, due to which she came to report in the hospital. In September 2014, she developed joint pain, fatigability and feverish feeling along with photosensitivity, and until 15th Feb, all his symptoms increased till the time she developed weakness. She became fatigued and her joint symptom, her joint pain increased gradually, along with the appearance of a rash on his face, with redness of nose and cheeks. And when she started developing dyspnea and shortness of breath on minimal exertion, then she reported in the hospital. Before that, she was being treated in the civil. When we examined her, we found that she had the pallor, she had oral ulcers, she had malar rash, she was febrile, and on joint examination, it revealed the synovitis of knee joint and hand joints. You can see the malar rash on her face, and also the oral ulcers, even the mucocutaneous ulcers are visible. She had also vasculitis on his nail folds. And on chest examination, she had crackles on both lung fields. Rest of her examination was normal. On lab examination, she was found to have low HB, low platelets and increased ESR, which showed the presence of some inflammatory disease in his body. Worth mentioning that her on lab test, her ENA was positive, her DNA came to be positive, and her complement were reduced. Her serum, her BC profile was negative. Her serum ferritin shows the presence of inflammation, some inflammatory or immune pathology. Her RA factor was positive. Rest of her ENA profile was negative, and rest of her lab tests, including antiphospholipid antibodies, blood sugar random, urinary proteins, renal and liver function tests were normal. On echo, there were no pericardial effusion, and NCSE, EMG and ultrasound level were normal. On chest X-ray, she was found to have soft, fluffy, scattered shadows with evident air bronchograms. Her HRCT revealed discrete nodular opacities in her both lung fields, just like that. These were actually the pulmonary hemorrhages due to the lung capillary vessel, due to the lung vessel vasculitis. You can see the focused image of her pulmonary hemorrhage. So on the basis of her history, her presentation, we made differential diagnosis of systemic lupus erythematosus, drug-induced lupus, or some systemic vasculitis which presented in a way. And the rare differentials which we included were rheumatoid arthritis, scleroderma, inflammatory myopathies, and sarcoidosis. But her immunological, her clinical criteria fitted in systemic lupus erythematosus, as we see that the 11 points, 11 criteria which are given to diagnose for SLE patient, 4 must be positive to diagnose the disease. But she had serositis shown in red, oral ulcers, she had arthritis, she had photosensitivity, her blood was involved because she had raised ESR and thrombocytopenia, her ANA was positive, and her DNA was positive, and she had the malar rash. So she didn't she didn't have renal involvement, neurological manifestation, and discoid rash was only 3 were not present. Rest all the criteria was fit. So on the basis of these, she was diagnosed as systemic lupus erythematosus, and we transfused her with 2 RCCs, and she was given broad spectrum antibiotic to cover the superadded pneumonia in the context of pulmonary hemorrhage, and she was started with the methylprednisolone. She was given a very heavy dose steroid to suppress the flare of SLE. So we started prednisolone on full dose of 1 mg per kg body weight. Usually it constitutes 5 tablets twice daily. Full dose for the 1 month and gradually tapered off over the next 6 months. Injection cyclophosphamide was started in divided doses. Total 6 doses were given 2 weekly, and hydroxychloroquine was given for joint symptoms and malarash. So her fatigability improved, she became afebrile, her ESR came down, her chest X-ray shows clearance of pulmonary hemorrhages, and her malar rash reduced. You can see the clinical improvement. She became asymptomatic after about 2 months. She became physically active, and regular follow-up was advised. Now, case discussion: lupus mean a wolf, because erythro in Greek word means red, wolf, because human face resembles as that a wolf has, some wolf has bitten somebody. So classical, it involves the middle age. It is common in 2nd, 3rd and 4th decade, and non-classical manifestations are also present. You can see the Fernandez macros. He was Japanese president. He also suffered from SLE. Michael Jackson also suffered from SLE. Louis May Alcott. These are famous celebrities suffered from SLE. It's usually common in urban areas, in Asian populations, and Afro-Americans more than Europeans. Female preponderance is very common. Female prevalence in the ratio of 7:1. And adult age, in few countries, 15:1 have been recorded, female to male ratio. Age of onset is between 16 to 55 years of age. The pathogenesis of SLE involves, has been traced exactly, but the scientists say that ultraviolet exposure, microbiological response of the body, involvement of different kind of drugs, these are the environmental stimuli which are involved in pathogenesis or initiation and triggering of the immune pathogenesis. Some HLA, DR3 and 2 individuals are also susceptible. There are some immunoregulatory genes which have been found to be involved in pathogenesis of SLE. The complement level and hormonal level represent a possible etiology of derangement of immunological system. So in immune proliferation, it has been observed that the high ratio of CD4 to CD8 cells have been found. Hyperactive and B cell and T cell activation has been found. And also after the B cell T cell activation, the process of apoptosis and self-exposure ignites the process of immune pathogenesis. So American College of Rheumatology has revised the criteria. Criteria involve the serositis, mean ascites and pleural effusion can be the clinical manifestation. Oral ulcers are common in mouth and nose. They are usually painless. Arthritis is non-erosive, involve 2 and more peripheral joints. Photosensitivity of the face, including discoid and malar rash, it comes in the clinical diagnostic criteria of SLE. In blood, hemolytic anemia can be found, leukopenia, lymphopenia, and thrombocytopenia can be found in these patients. Renal involvement occurs in the cells of proteinuria, more than 0.5 gram per day proteins, along with cellular constant urinary. Anti-nuclear antibodies include the diagnostic criteria. In immunological profile, we order anti-dsDNA, anti-Smith antigens, anti-phospholipid antibodies, and anti-cardiolipin antibodies. This patient also represents a false positive VDRL. Syphilis serology due to the cross reaction of antibodies. Neurological manifestation occur in the form of convulsion and psychosis, Mallet rash and discoid rash. All these includes the criteria. So 4 out of 11 features, serially or simultaneously or serially, involvement has a high sensitivity of 85% and specificity of 95% for SLE. This also there is a SLE classification has also been described to diagnose these patients. The drug-induced lupus, you can see on the screen the possible drugs which can involve in the pathology of drug-induced lupus. Common drugs which cause drug-induced SLE are chlorpromazine, methyl-dopa, hydrolazine, procainamide, isoniazid, quinidine, minocycline, and anti-TNF agents like infliximab and etanercept. So we can also have possible association which are given on the next 2 vertical lines. Drug-induced lupus has a bit different clinical features as compared to classical SLE. In drug-induced lupus, constitutional symptoms like fever, fatigue, and myalgia are less common. Cutaneous manifestations are usually not found, and there is no renal and CNS involvement in drug-induced lupus. Common finding we can have are the antihistone antibody positive in 90% of the cases of drug-induced lupus. Those patients who present with serositis, joint pains, and systemic clinical manifestation of systemic inflammatory response of the blood, and they are usually dsDNA negative. Drug-induced lupus treatment involves first that you will stop the drugs and you will give NSAID, hydroxychloroquine, and possible role of steroids have been described in these patients. So in neonatal lupus, some babies who are born to a mother who is SLE positive can have the SLE positive baby. In these patients, anti-SSA and anti-SSB, anti-Rho and anti-LA antibodies are positive, and the babies present as the manifestation of rash. As you can see, a faded rash on the thighs and calf muscles and calf area. Also you can see a faded rash. The baby has cytopenias on blood, complete picture. Baby can have hepatitis with hepatomegaly, and baby can present with congenital heart blocks and fetal bradycardia. We'll give dexamethasone to treat the fetal bradycardia, and we'll do permanent pacing to prevent the heart from going into cardiac arrest. You can see the Mallet rash in babies. Here you can see Mallet rash on face. Here you can see the oral ulcers and also Mallet and some discoid rash. Here is the discoid rash. There is also a selena modification to monitor the disease and to check that how disease is going, and to check the disease progress, and to assess the severity index or activity index of SLE. There is a selena modification criteria which has specific points. You will note the clinical manifestations. Each clinical manifestation has specific points, and then you will add the points, and The SLE modification criteria, if he has more points, then the disease is very active. If has less, disease is very mild. Mild disease is treated with NSAID and hydroxychloroquine, while severe flares are treated with immunosuppressant and steroids. Autoantibodies which become positive in these diseases are commonly ANA are positive in 96% of the patient, and anti-dsDNA are present in 78% of the patient. Rest of the antibodies also become positive in different percentages. Now I will revise the treatment summary of this disease. Like we'll give first of all NSAIDs to treat the fatigue and fever, and to decrease inflammatory response. NSAIDs are given for joint pains. Low to moderate dose steroids and hydroxychloroquine are given for mild disease, like if patient has fever, rash, arthritis and sinusitis only, you will treat with NSAIDs, I repeat, steroids and hydroxychloroquine. And in chronic lupus arthritis, you will add methotrexate also, and in moderate to severe lupus, which involves the renal and CNS and lungs, we will give high-dose steroid along with immunosuppressant like azathioprine, mycophenolate and cyclophosphamide. Resistant lupus is treated with rituximab, while the rest of the drugs which have a symptomatic role like statins to decrease the lipid profile and to prevent atherosclerosis, anticoagulants are given because SLE also causes DVTs and pulmonary embolism. ACE inhibitors are given, and belimumab, Benlysta, these are the specific targeted therapies to suppress B lymphocytes. Pulmonary manifestation come in the form of shrinkage lung syndrome, pulmonary hemorrhage, cryptogenic organizing pneumonia, and ARDS can occur. Pulmonary hemorrhages, patient present with shortness of breath. These are due to the capillaritis and immune complex deposition in the pulmonary vessels. Patient presents with shortness of breath, hemoptysis and cough. Chest X-ray will reveal bilateral infiltrate, and bronchoalveolar lavage fluid will show hemocytin-related macrophages. Lung biopsy can be done. We will treat pulmonary hemorrhage with aspiration, infection control, and the systemic immune modulatory drugs will be given. In the form of high-dose steroids, cyclophosphamide, plasmapheresis is carried out especially in the patient of SLE who present with severe flare in the form of pulmonary hemorrhage, and mechanical ventilation may be needed in these patients. Lupus cerebritis manifest in the form of organic encephalopathies, mental status changes in the form of fits. Cranial nerve involvement can be there in SLE. Spinal cord involvement occurs, but it is rare. Some patients present with venous sinus thrombosis and stroke. Lupus cerebritis, the same workup will be carried out with the baseline investigation and ANA and dsDNA, and we will also order anti-neuronal antibodies in addition to ANA and dsDNA, along with anti-phospholipid antibodies and anti-ribosomal protein antibodies. In imaging, we will carry out MRI and magnetic resonance angiography and venography of the brain vessels to check for the thrombosis and inflammatory status of the brain. Brain biopsy can be done, but rarely it is done in different centers. The treatment will be aggressive in lupus cerebritis. We will give high-dose steroids, hydroxychloroquine, anticonvulsants and anticoagulants, along with immunosuppressant like cyclophosphamide, azathioprine, mycophenolate, bufitil, and newer therapies are being given. In lupus nephritis, there can present in 6 classical forms in the form of minimal mesangial lupus nephritis, mesangial proliferative, focal lupus nephritis, diffuse lupus nephritis, membranous and advanced sclerosing lupus nephritis. These are the 6 histopathological manifestations of SLE in the kidney. So This is a treatment plan of lupus nephritis. We will not go into the detail of treatment. Last slide, we can have, if we calculate the statistics of involvement of different system in SLE, arthritis is common in 98. Arthritis is common in 98% of the patients. In our population, mallow rash occurs in 64% and oral ulcers occur in 58%, followed by photosensitivity in 36% of the patient and followed by renal and hematological involvement. While serositis, lupus cerebritis and hair loss is very rare. Complements are present at the low level because complements are consumed in immunological process. So commonly system involved are musculoskeletal followed by cutaneous, then hematological system involved, renal involvement followed by the rare involvement of CNS, pulmonary system and cardiac system. They are rarely involved. So take home message, summary, conclusion, I will say that SLE presents with wide variety of manifestation and life-threatening complication. It requires multidisciplinary approach and strict vigilance for diagnosing a patient, because if we will not diagnose a patient, we lose the patient. Thank you.